Live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research Education Foundation. To introduce today's topic and speaker, I hand over to our chairman, Dr. John Mukhopadhyay.
Good evening, everybody. Welcome to this evening series of webinars for postgraduate students and young orthopedic residents. We are back to our normal weekly schedule after 8 weeks of pelvic and acetabular fractures. And today we are going to talk about rotator cuff repair. We have Dr. Arvind Gupta from Paras HMRI Patna, who's one of our team, who will be talking to us about rotator cuff repair. So over to you, Arvind.
Thank you, sir. Thank you for the opportunity. Good evening, everyone. I'll be talking on basic rotator cuff evaluation and treatment part and some recent update about this treatment. So I'll start with this evaluation with the history. In history, most of the time, patient will complain of pain that will be around shoulder, and he will have difficulty in lifting the shoulder, at the same time keeping it forward and backward also. And any overhead activity, patient will have problem with this. And this shoulder pain will get exaggerated in the night. So mostly all these patients present with all these history. This may be associated with trauma, or sometimes it may be a traumatic one. And in examination, it should start with the inspection. That will be inspection from the front, then from the side, and also from the back. And in inspection, look for the atrophy in the supraspinatus fossa, infraspinatus fossa, atrophy of the deltoid, and all these. Can see here there is marked atrophy in the infraspinatus fossa. Next is the palpation. Palpation of all the bony landmark, starting from the lateral edge of the acromion, posterior part, clavicle, acromioclavicular joint, long head of the biceps. The Codman had described the direct anterior to the anterior margin of acromion. There will be tenderness. That is called as Codman sign. This is indicative of rotator cuff tear, particularly the supraspinatus. The next is the range of motion, that is active, if patient is able to do it, then followed by the passive range of motion. And last, there may be associated pseudo-paralysis. And there is complete tear of the supraspinatus, infraspinatus, and patient will be unable to lift the shoulder at all. So though power is intact, but patient is unable to lift the shoulder. So this condition is called as pseudo-paralysis. The next is the painful arc syndrome. Patient will have pain in between 40 degree to 120 degree of abduction of the shoulder joint. This is indicative of, again, subacromial pathology that may be, you can see at the angle of around 80 degree, this shoulder is very painful. So again, this is indicative of subacromial pathology, maybe supraspinatus tendinosis or tear. Next is the knees impingement test, in which the shoulder is placed in the forward flexion and internally rotated. So the greater tuberosity comes in the coracoacromial arch or under the acromion. And if there is any pathology in the subacromial space or with the supraspinatus, patient will have pain. Similarly, the Hawkins-Kennedy impingement test, in which the shoulder is at 90 degree of flexion, with elbow is again 90 degree, and there is internal rotation. So again, this leads to bring the greater tuberosity under the subacromial arch, and this will be painful. The next is the job test or MTCAN test. This is for the supraspinatus, in which the shoulder is abducted and internally rotated. So in this position, the humeral head comes directly in the line of supraspinatus. So in this position, supraspinatus is the only abductor. And then patient is asked to elevate the forearm against the resistance of the clinician. And if there is tear of the supraspinatus, then he will have difficulty in lifting the arm. The next is the drop arm thrust. Again, patient is abducted and asked to keep the arm in abducted position. But if there is tear of the supraspinatus, patient is unable to hold in this position. So this is called as drop arm test. Again, very sensitive to this supraspinatus tear. The next is the external rotation lag test, in which the arm is kept on the side of the body and the elbow is flexed at 90 degree, and bring the forearm in external rotation. And at this position, ask the patient to hold in external rotation. If there is tear of the infraspinatus, then patient will be unable to hold in this position. Here you can see on bringing external rotation, patient is unable to hold in this position. Here you can see the arm in the side with external rotation, the prominent infraspinatus muscle is there. So in this position, infraspinatus is the external rotator of the arm. The next is the Pate test or hornblower sign. Pate test is for again infraspinatus and teres minor, when the arm is abducted at 90 degree and the elbow is flexed, and then bring the arm in external rotation and again ask the patient to hold in this position. So here you can see this is affected side. The patient is unable to do the external rotation. Here patient can able to do this external rotation at 90 degree of abduction and elbow flexion. The hornblower sign, in which patient is asked to bring the hand to the mouth. If there is tear of the teres minor, then elbow will be up, like shoulder will be abducted. Only then he or she can bring the hand to the mouth. So again, this test will be positive when the shoulder is abducted. The next is the lift off test. This is for the subscap, the palm on the back, and ask the patient to lift the against the resistance. If there is tear of the subscap, then patient will be unable to do that. Again, next is the belly press sign, in which the hand should be at the belly, and then ask the patient to press it with the elbow in the line of the body. When there is tear of the subscap, the elbow will fall behind the line of the body. So this test will be positive. Because of the torn subscap, patient is unable to internally rotate the arm. Here you can see when he is pressing the belly, elbow is going down. So this is the belly press sign. Then the bear hug test, in which the arm is placed on the opposite shoulder, and then ask the patient to apply the pressure against the resistance that is provided by the clinician, and he is unable to do that. It means again tear of the subscap is there. Then in the last, there will be increased external rotation of the humerus. You can see this is the subscap which is attached there. If it is torn, then there is no constraint for the external rotation of the humerus. So here you can see there is excessive external rotation of the humerus. So this is increased external rotation. Next, this is the patient. You can see this drop arm test is positive. Then the elbow is flexed at 90 degree and external rotation lag test is positive. Patient is unable to hold in external rotation position. At the same time, here you can see patient is unable to do the flexion of the elbow. Also, there is a difficulty in extending the elbow also. Along with all these, you can see there is atrophy of the deltoid muscle is also there. There is marked atrophy, also atrophy of the infraspinatus fossa and all these. So in spite of being all the signs of rotator cuff tear is present in this case, but patient is unable to flex the elbow at the same time extend the elbow also. So this was a case of brachial plexus injury. So whenever we are evaluating for the rotator cuff tear, we should keep in mind about the brachial plexus injury also. And this will be vice versa. Whenever there is brachial plexus injury evaluation, also keep in mind about the rotator cuff tear. So in the investigation, we have X-ray, ultrasound, and MRI. In X-ray, it should be AP view. Here we can critical shoulder angle we can calculate, which is along the long axis of the glenoid and from the inferior border of glenoid to the margin of acromion, and any angle that is more than 35 degree, usually associated with high risk of rotator cuff or subacromial problem. The next is AP view in 30 degree of abduction, and look for any superior migration of the humeral head, whether it is there or not, because this superior migration of humeral head is associated with rotator cuff orthopathy. And in such type of cases, when there is superior migration of humeral head is there, the failure rate with the repair of rotator cuff is very high. So classification has been given for this humeral head superior migration about the rotator cuff arthropathy. And the broad classification is type 1 and type 2. In type 1, there is no superior migration. And in type 2, there is superior migration is there. And again, it is divided into A and B, both 1 and 2. So in 1, the femoral head is there, but there is a humeral head is there, but it is the acetabolization is there. And the 1B, there is medial erosion of the glenoid. And type 2, there is superior migration is there, 2A, and 2B, there is superior as well as the anterior subluxation is there. So this after this, the next investigation is MRI, which is very accurate about the tear. Can also pick up the tendinopathy, fatty degeneration in chronic rotator cuff tear. MRI pick it very well, and associated other pathology of the labrum, long head of the biceps, capsule, and other part. So classification has been given for the rotator cuff tear, help in the management, whether it should be conservative or operative, and different classification is there. Depending upon the size, 0 to 1 is a small, and more than 5 centimeter is massive. Massive rotator cuff tear is also called as when there is involvement of 2 or more than 2 tendon, like supraspinatus both or associated subscap and teres minor, that is massive cuff tear. Another classification is for the partial cuff tear, and it's depend upon the thickness. When there is 25% or less than 3 mm, it's grade 1, 25 to 50%, then grade 2, or more than 50%, that is usually more than 6 mm, then grade 3. And also whether it is located, whether it's on the articular side or it's bursal side or it's inside the tendon. So this is classification for the partial rotator cuff tear. Then about the fatty degeneration, Gottelier described this fatty degeneration staging, vary from 0 to 4. In 0, there is no fat at all. And in 4, the percentage of fat is more than the muscle in the cuff. Then the recent classification by the Davidson and Burkhardt about the depending upon the geometry of the cuff tear. Again, this help in the surgical management, whether it's crescent tear like this, treated with double row rotator cuff tear, U-shaped, again plain this double row. And there is L-shaped, you can see here or here, L-shaped. Then the margin convergence, the suture first should be applied, and then rotator cuff double row again, and there is massive cuff tear, more than 5 centimeter is there, or if there is more than 2 tendon is involved, then and it is immobile. Then this treated with the partial repair of the cuff. Sometimes it's become difficult or impossible to bring back complete to its the anatomic area. So in such type of cases, the partial repair is recommended. So this geometric classification help in management of this surgical management of the cuff. So treatment of the cuff, it's depend upon the activity of the patient, age of the patient, whether it's traumatic or atraumatic, what was the size of the tear, whether it's partial or whether it's complete. If it is partial, then which side, bursal or articular side. Usually bursal side should be treated surgically. And about the conservative treatment, the chronic atraumatic cuff should be managed conservatively. And in JBGS 2014 says very good result, almost 89% success rate at the end of 2 years. Another paper, a multicentric cohort study, again says 85% of the satisfaction rate with atraumatic chronic cuff tear. So what is the natural history of this rotator cuff tear? If there is full thickness tear, there is high chances of progression, particularly those who are traumatic one. Traumatic one will have 50% progress over 5 years, and atraumatic, asymptomatic one will have 22% of this progress. And as the size of the cuff progress, there will be retraction. At the same time, there will be fatty infiltration also. And this fatty infiltration will persist even if we repair the cuff. And if you do repair of the cuff, there is 85% of the pain relief. Strength vary from person to person, and also depend upon the tear size of the cuff. At the same time, the quality of the life will be improved. So about the operative management indication, usually the traumatic one, which is younger, having severe night pain, and conservative treatment has failed, and with the serial MRI, there is progression of the tear. All these category of patients should be managed surgically. And there are some relative contraindications are there, like superior migration of the humeral head, heavy smoker, those having not much demand of the shoulder joint, and also the massive fatty infiltration of the cuff. All these are the relative contraindications. So about the repair technique, it can be done by open method or orthoscopic method, maybe single row or double row. Anchor may be knotted, knotless, or maybe transosseous repair of the cuff can be done. There's a lot of discussion about the single row versus double row. The systemic review says there is not much difference till now in between the single row and double row. However, some study says with massive cuff tear, double row having a little bit of advantage in terms of healing. But functionally, there is no difference between these two at all. In recent advancement, there is a lot of use of biologics after the repair of the cuff or during the repair of the cuff, which may be cellular therapy, which is the marrow stimulation technique at the tendon insertion, which usually we do with microfracture all at the anatomic footprint of the cuff, so that there is lot of growth cells comes through the marrow. And another technique is the delivery of progenitor cells at the repair site after the repair. That is in form of local injection, enrich scaffold, and other thing. Also, we can inject the growth factor like PRP and other growth factor also. And after the repair, we can use the scaffold augmentation, that may be synthetic or maybe allograft patch or genogenic patch also. All these people are using. There is great promise as the new treatment option. the increasing body of the basic science study to support the potential clinical advantage, and the high quality clinical data to support the regular use of all these is still lacking. And sometimes there is irreparable cuff tear is also there. So irreparable cuff tear treatment depend upon the presence of glenohumeral arthritis or not. If there is no arthritis, so even partial repair having almost 67 to 92% success rate. Like cuff is not coming to the anatomic footprint of the humeral head, but with the margin convergence and approximate as much as possible in help in gaining the power of the shoulder joint. At the same time, it reduces the pain also. The next is the tendon transfer, that is latissimus dorsi very commonly, and there is also the teres minor transfer is also done for this tear of the cuff that is irreparable. Recently, there is superior capsular reconstruction that is started by Mihata from Japan using tensor fascia lata, and now there is allograft is also there, and artificial patch is also used for the superior capsular reconstruction. Here, what you do, the tensor fascia lata or artificial graft is knotted over the humeral head and the superior margin of the glenoid. So it's prevent the superior migration of the humeral head. So this prevent the development of arthritis and the relief the pain also. So this is the superior capsular reconstruction. And next, when there is arthritis is there along with irreparable cuff tear or low demand patient or older patient, the reverse shoulder orthoplasty can be done. So rotator cuff tear is a very common source of shoulder pain. Diagnosis can be suspected clinically with the test, and confirmation require MRI of the shoulder joint. Treatment can be non-operative, that is conservative management, that include the physiotherapy, injections, oral medicines, and operative, depending upon the chronicity of the symptom, severity of the tear, degree of the muscle fatty infiltration, patient age, and the patient activity demand. Thank you.
Okay, thank you, Arvind. That was excellent. And we'll start off with any questions from the DMV. Just before this start, you mentioned MRI and X-ray. What about ultrasound? You didn't talk much about ultrasound for the diagnosis of rotator cuff injuries.
Ultrasound is also very good diagnostic tools, and sensitivity, specificity almost matches the MRI also.
It's much easier to get an ultrasound. And in fact, it's becoming more popular where many surgeons are doing their own ultrasound examinations, and so they can do dynamic studies, etc. at the same time. And also, it helps with their localizing of injections if they're planning to give injections.
Yes.
So you can talk about local injections either very much.
Yeah, in conservative management, we have local injection, physiotherapy, and oral medicines also. When there is lot of inflammation, sign and symptom is characteristic of the subacromial impingement, along with either partial tear or tendinopathy type of thing of the cuff. Then this can be treated very well with subacromial injection. That can be done blindly also or with the help of ultrasound. And you are absolutely right. In the West, and I spent some time with Dr. Jody Beer. He diagnosed all the cuff with this ultrasound only. He does by himself only. And many a time he use the help of ultrasound for putting injections also. We are also using ultrasound with the help of radiologists for injection part of purpose, particularly when we are using the block of the supraspinal nerve, suprascapular nerve. That provide almost 50% sensory part to the shoulder joint. So many a time, lot of pain in the subacromial space or shoulder joint. So this subacromial supraspinatus injection help a lot.
The thing you did not elaborate too much on is acromioplasty. Is that now not used so much, or early on that used to be a very essential part of any rotator cuff treatment?
So many a times we have to calculate the critical shoulder angle. When it is more than 35 degrees, then it is advisable to do the subacromial decompression in form of acromioplasty. But usually cracoclavicular ligament, cracoacromial ligament that was supposed to be a stabilizing structure, initially it was taken off, but nowadays it should not be touched as much as it's not causing too much of impingement. The lateral end of the acromion, particularly the anterior half, should be taken off. Whenever there is angle is more than 35 degree or there is hook type of acromion.
So any questions on the, I think there were some
Yes,
questions.
yes, one thing which Gautam has asked is about acetabulization. You have mentioned, sir. And what are the features on X-ray the DNB should look for?
So I have.
If you saw that X-ray, you'd know what he meant.
Maybe,
So
yeah,
you can just show that slide again. They might. So normally what is the shoulder joint is the head is not covered by the glenoid, okay?
Yes.
And while in the acetabulum, the entire head is covered by the acetabulum, okay? So if you look at it, it looks like between the glenoid and the acromion, it's formed an acetabulum, okay? So there's another one where you showed the classification in that one.
Yeah. So this acromion is act as the acetabulum, and the head of the humeral is act as a femoral head. So this is the acetabulization of this.
So if you go to that whole area, not including the glenoid, I think. Yeah. So look at that. Okay, this one, the one on the, yeah. So that whole thing looks like an acetabulum covering the head. Okay.
Stabilization.
Yes, sir.
So humeral head is like femur, and this the complete coracoacromial arch is look like a stump.
So the other things what he has asked is about role of CT scan in case of rotator cuff tear. Is there any role?
Usually when there is lot of medialization of the humeral head is there and you are planning for reverse shoulder orthoplasty, then you can ask for the CT scan to look for the status of the glenoid. When there is erosion of the glenoid, this reverse shoulder orthoplasty become difficult. So that part can be evaluated very well with CT scan. And other than that, there is not much use for this rotator cuff, particularly as such repair part.
So value for any bony defect or that you want to see, not for the rotator cuff tear as such. You won't see that.
And so you have mentioned in your talk about the partial repair. What is that, sir? Also.
So many a time there is a partial tear of the cuff, which may be dorsal side, that is toward the acromion side, or sometime it may be articular side. Particularly throwing athlete will have problem with the articular side. Fiber get torn from the articular side. So when there is dorsal side problem is there, it means there is extrinsic reason behind the tear of the cuff. So until when you will not remove that part, like hook acromion is there, there is acromioclavicular joint arthritic part is there. So until unless you will not remove that part, that the dorsal impingement will not go, and this tear will continue. So usually this dorsal side tear should be treated surgically in form of subacromial decompression, as sir has said. the acromioplasty along with all the excision of the bursa. And if AC joint is also involved, then also the saving of the AC joint part. And also the aggressive rehab is very important for this partial.
So, in few of the paper, they have mentioned about the debridement. So in few old papers, sir. So is there any role of debridement in case of rotator cuff tear when?
Yeah, many a time this irreparable cuff tear is there. So people used to do the debridement, subacromial decompression, and then the partial repair. Whatever the cuff tissue can be repaired, they do repair part of the cuff. And it's not always possible to bring back to the anatomical footprint. So maximum the part that can be repaired, they repair it and do the subacromial decompression, thorough subacromial decompression. So this is the recommended treatment for the massive rotator cuff tear, those who are having low demand patient. Only pain part is there. There is not much functional requirement is there. Then this type of patient can be treated with decompression.
So, when you are going for OT, it's always you take an MRI scan and you should know that it is repairable or not. Is it possible, sir, in OT that sometimes if you open and then it is just like that it cannot be repaired? Is that situation in?
Yeah, when there is massive cuff tear is there and lot of fatty infiltration are there. So that you should evaluate on the MRI. At the same time on this, the clinical examination is also, and there is very significant pseudo paralysis is there. And that there is marked atrophy of the supraspinatus fossa, infraspinatus fossa is there. So such type of patient, you can decide this is not repairable. And even if you go in and you find this tissue is not repairable at all, so you do subacromial decompression and do the partial repair as much as possible.
So, sir. Yeah.
So it's important to try and assess that before you go into OR. Okay, that's the thing. Okay, because you may have a totally different option. You may today, especially with rotator with reverse shoulder arthroplasty, if you have a cuff tear which is irreversible and you're having signs of propathy, then you might decide on a totally different method of treatment, which would be the RSA. So I think it's important to try and assess, or you might have to do some tendon transfer like the latissimus. So it's good to know that before you go into OR rather than, but there may be occasions where you think you can repair it, and when you go in there, you find the tissue is not of a good quality and very friable, and then you may have to opt for something like a compromise maneuver with a partial repair, where you get as much of it together and the rest you suture onto the head with anchors, so that at least it has some function.
So, if it is an elderly patient, then we have option of like reverse shoulder or arthroplasty. If it is young, high demanding patient with massive tear, what option we should have, sir? We should look.
So it start from the tendon transfer, as sir has said. Another option, we have the superior capsular reconstruction. You assess the patient. If patient power is good, deltoid power is good, and other thing is good, then you do the superior capsular reconstruction. It has started from the Japan by Mihata, and what the reverse shoulder arthroplasty was not approved by the Japan government, and their life expectancy is on higher side. So a lot of patients with irreparable cuff tear they faces. So they started using the tensor fascial lata, and they suture it over the superior part of the glenoid, at the same time over the humeral head also. So this prevents the superior migration of the humeral head, and at the same time the remaining cuff they used to suture with this tensor fascial lata, and aggressive rehab, very good rehab, and the result is very wonderful. Even at the end of 6 year or 8 years, they have published it. The patient satisfaction is more than 90%. So they are almost nil for the reverse shoulder orthoplasty. Similarly, the Jody Burkhardt, he also does lot of this superior capsular reconstruction for the failed cuff repair or irreparable cuff repair. They have lot of patients, and I have seen personally 10-year follow-up of this superior capsular reconstruction with very good power, and there is no pain at all. So if this surgery is done in a good manner, so result is really wonderful. I have seen some follow-up also.
Another question what they have asked is about the timing of tendon transfer if you're planning for, and what all tendon we can use for that.
So latissimus dorsi already very well described for this tendon transfer, and the technique of attachment over the humeral head is vary depending on which function you want, whether it's supraspinatus function or whether you want infraspinatus function. So timing again, it's the younger patient with irreparable cuff should be treated with this tendon transfer.
And so between the open and the arthroscopic technique, is it a surgeon's choice, or do we have some criteria for that someone can go for open?
Usually it's surgeon's choice, and if you go through the literature, open or orthoscopic method having equal result.
So I think if you went back a few years, many people used, when the arthroscopy of shoulder had not yet become so advanced, a lot of people would do a chromioplasty, which would be arthroscopic, and then they would do the repair open, or mini open repair. Okay, so because the arthroscopic repair initially was not as effective, but with time and techniques, and especially now there's so many devices which help you do the surgery. Okay, so you have various
particularly knotless
anchors, etc., which make surgery through the scope a lot easier than it used to be.
So when it is an open technique, then what is the approach usually? What is the technique?
So usually you take the incision through the deltoid, and it should not exceed 4 to 6 centimeter down, because where your axillary nerve comes. So you take a suture part in the lower part of the deltoid splitting, and you separate the deltoid. Then you will find the subacromial bursa is there, or subdeltoid bursa will come. Just take it off and you will see the cuff. So in fact, the mini open technique is much more easier in comparison to the orthoscopic method. At the same time, it saves a lot of time also. It's quick also. And
so the approach is similar to what you would do for your tuberosity fixation, okay?
So direct lateral approach. That one.
Direct lateral approach.
Yeah.
Okay,
the incision, people either make a vertical or a transverse incision, some people, because that heals more cosmetically. That's the only difference. Otherwise, what you do to the deltoid and underneath is the same. And you can also do the chromioplasty through that. Then you would extend the incision a bit and do your chromioplasty.
And it's always advisable to have exposure of this mini open technique repair also.
Yeah.
Many a time in early career, you may have problem with the orthoscopy part, because you need good assistant, very good blood pressure of the patient, less than 90 mm of edges, so that there is no any blood in the field. And if there is any problem, don't keep any ego, just do mini open repair and it become very easy.
And so when you're going for a reverse shoulder arthroplasty, what you used to see, like what are the criteria that this patient is fit for reverse shoulder arthroplasty, or you can go?
The first thing, it should be irreparable cuff, and if there is any arthritic part is there, then I'll select this patient for the reverse shoulder orthoplasty. At the same time, other than that, there should be deltoid function intact, because it's the deltoid which works for your reverse shoulder orthoplasty. And
So,
at the end, whatever the this cuff part is there, try to do repair of that part with this your implant part. Like initially subscap release was left as it is, but nowadays people used to do repair of this subscap also. So try to do repair of this cuff, whatever it is left. But the deltoid function is priority. Before planning for reverse shoulder, must check for deltoid function.
Two things. One is deltoid and the other is the glenoid. There has to be a reasonable bone stock in the glenoid, otherwise it becomes a big problem.
So in reverse shoulder, that is actually the glenoid acts as a ball, and this thing, the humerus side is the cup. So
it works by increasing the lever arm of the deltoid muscle. Okay. So normally what happens is the doesn't initiate abduction. Okay, but when the lever arm is increased, it can initiate abduction. Okay. So the rotator cuff function is taken over by the deltoid. Now there are some reports of the deltoid gradually fatiguing after about 10 or 12 years with the reverse shoulder.
That's why it has started dislocating.
Yeah. So, and the second thing is to make sure there is no axillary nerve palsy, or especially in the post-traumatic ones. Okay, if the patient has injured his axillary nerve and doesn't have a functioning deltoid, then if you do a reverse, it's going to fail.
So, other than reverse shoulder arthroplasty, do you have any role of hemi or total shoulder arthroplasty in rotator cuff tear?
Well, so what is your most important part of your shoulder arthroplasty in trauma?
It's that when there is arthritic changes.
No. In trauma, I said, yeah.
That
what is the most important part of the surgery?
That
your tuberosity is back in position. Huh?
Yeah, yes, sir.
So that your rotator cuff functions. So if that's not functioning, the idea of doing an arthroplasty becomes, so that's why even in a fresh trauma case in an elderly patient, if you find there's no rotator cuff, they advise doing a reverse shoulder.
Reverse shoulder. Yes.
So I think for any form of shoulder arthroplasty, that is a total or a hemi, the rotator cuff must be functional.
So one question what they have asked is about the post-operative rehabilitation after surgical repair
of rotator cuff.
Yes, sir.
So basically arm should be kept in abduction of around 45 degree with lateral rotation for at least 2 to 3 weeks. That can be done with the Kramer wire under the axilla, that what we are doing. Or there is artificial made this shoulder abduction splint is there by different company is also there. So that should be there for at least 3 weeks. And after that, there is passive pendulum exercises we should start for further 3 weeks. So till 6 weeks, there is no active movement of the shoulder joint at all. Because if you see the literature, the reason for failure of the rotator cuff is aggressive movement or early immobilization on the shoulder joint. Because the healing part of the tendon to the bone takes very long time and it's very slow process. And in case when there is tendon is not very good, so you should give more time for this active mobilization of the shoulder joint.
Yeah, so active abduction is not started till 6 weeks. You can start pendulum movements a bit earlier. Okay, so at 3 or 4 weeks.
So initially it is abduction splint, sir.
Yeah, for 3 to 4 weeks, abduction is splint. And if tissue was not good or you think repair is not very mechanically sound, then you can increase till 6 weeks also.
And so one question what they have asked is about the guideline of timing of surgery when you are going for rotator cuff tear, fresh tear. Is it you do immediately or
So,
you wait?
so it's depend upon that which type of it is tear, whether it's traumatic or atraumatic. That is the main thing. Another thing, what is the age of the patient and what is the activity and demand of the patient. A very elderly patient usually having non-traumatic rotator cuff tear, like 75, 80-year female with non-traumatic rotator cuff tear, usually have little bit of dysfunction around the shoulder, having not much demand for the shoulder. So if there is pain, you can do conservative management, there is no problem. You can give the subacromial injection, analgesic and physiotherapy, and such type of patient does very well. And if it is young patient, though it's not very common cuff tear in young, but young in the sense the functionally demand shoulder joint is there, and it is traumatic one. So traumatic one should be treated surgically as early as possible, because with the time, if it is complete tear, this will progress. And as the cuff progresses, the retraction is started and fatty infiltration is started. So to prevent that, such type of patient should be treated surgically. If patient is very active, need shoulder function in a good way, then such type of patient should be treated surgically.
And so like in case of elderly patient, as you mentioned, there are asymptomatic rotator cuff tear. So if there is a painful patient with rotator cuff tear, so what differential diagnosis we should keep in our mind, like so that we should not treat that rotator cuff if it is asymptomatic and pain is generated due to.
How can it be asymptomatic if he has pain?
That means I just want to ask if there is some other source of pain with rotator cuff tear in that maybe a finding on MRI. So in those cases.
No, but if you say asymptomatic, then they shouldn't have, they won't have pain. Okay.
Okay. Yes.
That's a symptom. Now, what that symptom is due to, you need to find out. So you can have things like tendinitis, you can have calcific tendinitis. There are a lot of things which can just impingement syndrome without tear. Okay. Adhesive capsulitis in the initial stages is painful. So all these things you can have, which you need to obviously differentiate before you think of doing anything to the rotator cuff.
So one more question which is asked is about how much injection can be given. It's probably is asking what corticosteroid.
How much or how many?
How much? Yeah.
I think how many?
Sorry, how many? Sorry.
How many?
Okay.
Sir, from your.
So I would avoid more than 3, and I tend to usually just give 1, and then maybe if they benefit from it and they come back after some time, might repeat it a couple of times, but I don't like giving it multiple times. Yeah.
And interval between 2 injections, sir?
So that depends on what you're using. Okay. So if you're using something which is short acting like hydrocortisone, which was being used earlier, it used to be, I remember people used to give it weekly for 3-4 weeks. If you're giving depomedrol, I would give it only after 3 to 4 weeks.
Okay, sir.
So
I don't think there's any strong science behind it as far as I know. Arvind, are you aware of anything?
No, sir. Literature is not very conclusive.
Yeah.
But what I find is suprascapular nerve block.
Yeah, nerve block. That's also for this is quite a useful technique. The other thing is when you do your injections, so it depends also on what it is. So if you have bursitis, okay, so often it's bursal problems. So you need to not just inject the shoulder, but the subacromial bursa as well. Okay. So you inject the shoulder, but not the bursa. And the problem is bursitis or some kind of impingement. That's not going to help your shoulder.
So I want to ask about the subacromial balloon. I have read somewhere that there is some role in that one. What is that?
In UK, a lot of shoulder surgeon is using it. The balloon is a type of artificial, you can say, implant that is placed in between the subacromial space, the acromial and the humeral head. So it prevents the superior migration of the humerus. So in this way, it's prevent the rotator cuff arthropathy, that is the acromio-humeral arthritis thing. So basically, the biomechanics of shoulder joint is preserved. Even though there is no rotator cuff is there, but the shoulder is down at its normal position, it's not moving up. So patient is not having too much of symptom. So this is subacromial ballooning is there for cuff tear.
And just one last question, sir. For recent updates, what DNB candidates should know for their examination?
Yeah, what about the single row, double row? Double row recently has come with a little bit of advantage over the single row, particularly for the massive cuff tear. Second thing, the superior capsular reconstruction. Now very well researched and very well documented with very good outcome or irreparable cuff tear. Third thing, the reverse shoulder orthoplasty. That is also low shoulder patient demand, elderly patient, and the injection, particularly the bone marrow aspirates, the platelet-rich plasma. There is some literature says having advantage, but still the bigger clinical research should be in favor of using this. So all these are in market. Augmentation, patch augmentation. Nowadays, people, what they do is for irreparable cuff, they do the partial repair, and over that they augment with the patch. That may be yellow graft or any dermal tissue and other type of thing. So all these are the recent advancement in the cuff repair.
I think most of the thing we have covered, sir, and it was very nice and
Yeah, okay, that's great. All questions over?
yes, sir. We have.
Okay, great. So I think we should call it a day, and until next week, whenever. What have you got planned for next week, Janki?
Sir, we have been planning 2 or 3 things. One thing which I have requested you for talus fracture, and
I won't be able to do that next week because I'll be out. I've got too many things this weekend, so maybe the week after.
and then other thing, one more is about the shoulder dislocation that sir asked for, and one is phalanx fracture, and another one is like the practical exam is on
Okay,
the way.
We'll discuss it later.
Yeah.
So.
Yes, sir.
Okay, then.
Thank you so much.
Thank you, sir.
Sure. Bye.
Thank you, sir. Thank you.
Thank
Good
you,
night.
sir.